Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moore Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're
Welcome back to Curbsiders. We're actually live from my hotel room in San Diego for SHM 2024. And we have a cadre of some of our favorite people in this room to kind of do some recap. This is after the first morning session, and we all got to go learn a bunch of stuff. And now we just kind of want to share some of that with you. Meredith, how's it going?
Thanks, Moni. I'm doing great. Living my best life.
Yeah.
I always love a good conference. Get lots of good learning, okay food, but they had Dr. Pepper downstairs, so that was a thrill a minute for me.
And it's something new I learned about you today.
Yeah.
Which doesn't happen that often.
I know, it was special.
It's really special. Before we get too far into our dietary preferences, we're going to introduce our friends here. One that you are familiar with, if maybe not by voice, certainly by her stunning artwork that she does for us every episode that we do. Dr. Caroline Coleman, welcome back.
Hi.
And our other two friends also from the Atlanta VA. We have quite the cadre of friends there. Dr. Sneha Nurgankar. Well, would you like to tell us just a brief something about yourself?
Yeah, sure. Hey, guys. I'm also a colleague of Meredith, Caroline, and Moni. And I love ultrasound. I love procedures. And I love
Dogs.
Specifically
your dog, Cooper.
a Great Dane, yes.
A very large dog.
Yeah.
Gives me lots of anxiety.
Yeah.
Because I'm not a dog person.
Yeah, but he is the best dog ever.
Thanks.
Anytime.
And our last guest today is our friend, Dr. Harka Garthi. Would you mind telling us just a quick something about yourself?
Yeah, so hi guys. I'm of course a colleague of everybody in this room here. I've been in the hospitals at the VA and enjoy being in the academic atmosphere with all our residents.
Fabulous. So before we get too far into this, because this will be the opening, I think, for our whole recap, I guess, Moni, do you want to do some
Picks of the week?
Mm-hmm.
Yeah. So my pick of the week are two albums that are already out and one that is about to come out, I think. So the first is Ariana Grande's Eternal Sunshine. I just love that lady. She's such a great singer, and it's just funny to hear a pop star actively sing about therapy, which happens a few times in this album. And then she just has great kiss-offs. So, and then of course, the one that everyone's talking about is Cowboy Carter, which, not as twangy as I was expecting, but some real interesting stuff in there. Starts with the sitar. So as an Indian person, just really plugged at my heartstrings. Oh, are you proud of that pun?
I am.
Yeah. And then
I'm more proud that you recognized the pun.
Thank you. I've been working on it. And I guess I should have to, I feel like for the Swifties, I should say that I'm excited about the next Taylor Swift album. And I guess I am. It's coming out a week from yesterday. So from when we record this. So hopefully people liked it by the time it comes out.
I'm not a Swiftie, so back up a second.
Yeah.
So she's been recording a new album while she's been doing this tour.
I actually think this might have been recorded before.
Resident Swiftie. I can fill in the blanks.
Okay,
yes.
thank you.
It goes back a couple years, apparently, 2 years or so. So we've got some tea to spill on this upcoming album. Yeah.
Yeah, because I think the interesting thing was that people have been putting the chronology of when Midnights was recorded. Yeah. And then, of course, she's been doing all the re-recordings. And then this. And I think people's minds were blown because this will not include Travis Kelce, from what I can imagine.
Him.
Yeah,
it's all Joe Alwyn. Yeah.
Yeah.
Poor guy. Pray for him.
Really do.
Yeah.
What would be really funny is if she included a co-write from him on this one.
I mean, he's made a lot of money, so
because I kind of
wouldn't put it past him.
Do something like that. Okay. Anyone else want a pick of the week?
Well, you stole my two picks of the week.
Oh, I'm sorry.
I also was going to shout out Cowboy Carter. I don't know. I mean, women's sports right now is just couldn't be cooler. Just with Caitlin Clark, didn't win last week, but just women's basketball was a ton of fun to watch last weekend. So I think that would be my pick of the week.
No, I agree. Some of the best basketball I've seen in a while, actually.
Yeah. I mean, they crushed all the viewership or whatever you call that number records. I mean, almost 19 million for the women's final. So women's sports.
It was like an American Idol finale in the viewership. All right. Any other picks of the week?
I'll do one of mine. It's unrelated to music or pop culture or sports in any way. But as this will be the first episode back since I had a baby, mine is going to be this toy I bought my child. It's going to be linked into these show notes. Don't worry for everyone curious. But you can buy this movable crab for $15 on Amazon. And it has a sick EDM beat. And it's supposed to promote him crawling and everything, which he still can't do. But I cannot tell you how many times I've played this thing, and it has brought me endless joy, because nothing like a good beat when you come home from work and just watch the dog run into a corner and the baby be like, "What is that? I don't get it."
That crab has brought me copious amounts of joy, and
It's
I haven't
so
even
good.
met it yet.
I know.
Just the video that you have. It's amazing.
I know. So, yep, that's been what's been making my life good recently. So, with that, I think that's a great segue into what we've been learning here at SHM.
Fantastic segue. We are back on the saddle and clearly a little rusty. Okay. So we're just going to go around and talk about some of the things that we learned in this morning session. And it's probably easiest for me to kick it off. So I got to go to 2 talks, the first of which was shifting paradigms in heart failure and atrial fibrillation. And, honestly, it ended up being more of a history of sort of how we approach heart failure and kind of talking about how we just don't have the best data for HFpEF, which I think we can all agree about. And also kind of that moderate, or the 40 to 50% where it's like not quite full blown heart failure, but not quite not heart failure. And what the interesting thing that came up was that down the pike, hopefully soon, which I think a lot of us would agree with, which is studies about how maybe all this GDMT prescribing is like maybe not the most realistic thing on discharge. And so trying to shift some of the starting some of that to when they're actually still hospitalized and kind of going that way. So, because I know that I get like chest pain thinking about sending home some of our patients with 4 new medications that I haven't seen how they're going to respond to. And so some of these studies are supposed to be coming out somewhat soon. And so hopefully they will be coming out and kind of speak to that. But yeah, I found that to be interesting.
Yeah, because we talked about this last year at SHM, because it was like last year was totally like SGLT2s, like, the HFpEF studies had just come out and it was all the talk of the town and everyone was like, prescribe on discharge. And I felt when we came here, the prevailing question in all of those talks from the hospitalist was, but that's kind of scary to like put them on all of these meds. And so that's really interesting that it sounds like those studies are coming down the pipe, because I think last year at this time, that's what we were hoping would happen.
Yeah, well, kind of opposing that too, though, is how we're just like not great at prescribing it. Because I know like our hospital has initiatives on trying to improve that on discharge. They called it clinical inertia, where we just like don't do it because we're scared and that kind of thing. So it seems like probably do need to do a better job of prescribing it, but also hopefully getting more data on like whether or not sending someone home with 4 new medications before ever trying it's like the right way about going about it. So the second talk that I went to was caring for patients with disabilities. And it was framed as like what happened during the COVID pandemic and how that shifted. But it really was just kind of speaking greater to like, and I know it's a little bit outside of like purely clinical, but it really did strike me about how little I think about some of the things about caring for patients with disabilities. I think I see, a wheelchair ramp and our patients get Hoyer lifts while they're in the hospital. And I'd never really thought about, obviously there's way more than that. But then also when you discharge a patient, when they go to an appointment, are they even going to be able to accommodate a patient with a wheelchair? Which the speaker told this really, honestly, like it really made me upset, actually, story about how a patient she had seen in the hospital told her, like, she had asked her, why haven't you seen the specialist? It's been on your last 4 discharge summaries and instructions. The patient said, well, no one in that specialty is within 100 miles of me that'll see me. Just like being mindful that, we talk a lot about DEI, and I'll be honest with you, this is something that I never fully appreciated until hearing it, and just like really upset me that one, that I'm not as aware, and that we definitely have a lot of room to grow in that area.
That's interesting from a transitions of care standpoint. This actually just happened to me when I was on service last week. Actually, we had a patient who is legally blind and was potentially going to have to go home with IV antibiotics, and he lives by himself. So it was a whole thing. And just like all of the disposition planning, transitions of care planning that we were going to have to do, I felt like on admission, I was talking to him about it, and every day we were like having to troubleshoot through all of that. And it's interesting because it definitely, I think, was also playing into some of the care decisions we were making while he was there. So yeah, I think it's something like it probably actually should be something we're thinking about from time of admission because it's going to impact so much from discharge and transitioning into the outpatient setting. But that's wild to me that like potentially that high of like outpatient places, like when you think about it across the country, just may not even have the resources available to them to take care of everyone.
Close to 40%.
Yeah.
And the thing that I think that I had mentioned to you guys offline was we think, like I said, like the ramps are like what they need, but then once they actually get in the patient room, is like there a height adjusting bed? Is there even space to be able to lift the patient? Are there human resources to literally lift the patient to the exam table? Anyway, it was very moving, to be honest with you. But enough about what I learned, which I feel was a lot. Caroline, what did you learn?
Yeah, I got to go to one session this morning. It was called Gel Side Rounds, Integrating POCUS with Clinical Reasoning. And it was great. It was a case-based presentation. They laid out a couple of just POCUS principles in the beginning, which I thought were really salient. They broke down POCUS learning into 3 pillars, one of which was image acquisition, which we didn't focus on today, but we did get to explore image interpretation and integration into clinical reasoning and clinical practice. Some of that kind of higher echelon applications that I thought were really helpful. And some of the common themes they had from their cases that they went through, a couple were, preformed cases and they did a stump the professor at the end, where that ultrasound is really meant to augment the physical exam, not, created to replace it. So kind of showing how physical exam maneuvers, traditional ones without ultrasound, really integrate with these ultrasound augmented exam maneuvers was helpful. And they also broke down, as we moved through these cases, that ultrasound shouldn't be like a static measurement at the beginning of, when you meet the patient or admission, and just as like how we have diagnostic timeouts throughout the patient's case, like throughout their care. We can also have sort of like POCUS timeouts to assess their response to treatment or kind of troubleshoot when, for example, their creatinine isn't, responding as you would expect. So making it more of a dynamic tool as well, instead of kind of contrasting it with our traditional CAT scans or echoes, which seem to be like a one-time data point that we get in admission. So I thought those applications were really helpful.
I think that's a good point. I think POCUS is definitely becoming this thing in hospital medicine. I know for sure at our site where we're all a little bit biased, but it's definitely growing. I think it was a thing last year at SHM as well. Like you could see it was like a fair number of talks on it. But I think that point that it is to complement your physical exam and to be the dynamic point is really actually, I think, probably the 2 key points to like where we're using POCUS and where we should be using it in the future. Because I think one of the misconceptions I get caught into is like, oh, we POCUSed them on admission and now I'm still making decisions 3 days later on that initial POCUS, which is clearly changed, same as your physical exam has changed. So I think that's a really good point, is that complementing of those things. So I'm glad they highlighted that.
Yeah. I mean, I'm just bummed that this means I still have to physically examine patients. So I was just hoping I could replace everything with the ultrasound. So that was disheartening. But I know, guys, I'm sorry. Sneha, what did you learn?
So I went to the Sun Sand Stomach session, which is updates in GI. And it was very interesting because, as you all know, I'm very bad at math, and MDCalc is my best friend. So I learned 2 new risk assessment tools on MedCalc. So the first one he talked about was for upper GI bleeds, and that score is called the Glasgow Blanchford bleeding score, and it's used to sort of filter out patients who are high risk and who would need medical interventions, whether it be transfusion, endoscopy, or like surgery or transfusions, basically. And then for lower GI bleeds, they use the Oakland score, and that sort of tells you which patients are appropriate for early discharge and would benefit from outpatient diagnostic evaluation instead of having them remain inpatient.
Nice. I think we talked about the Glasgow one when we did GI bleed with Dr. Deere.
We did.
Oh my God, look at this memory.
That was one of our first episodes,
It
Meredith.
was. It's a while ago now.
2 years ago.
Yeah.
Yeah, somewhere in the late 300 range, if I recall. It's so funny because I think for the longest time, I thought that those decisions about scoping and not scoping were just a what I like to call attending dependent. And then I kind of started thinking back through the cases that I've seen, having learned about this score. And it is nice to know that there is something that's being used, because otherwise it just feels like, we're just doing what we want without data. So that's really cool. So I think that leaves us with Dr. Gorthy before we get to Meredith. Does that sound good?
It sounds great.
Yeah.
Okay, so I attended a session that talked about high value advice in medical education. So basically, this was talking about approaching medicine in sort of a framework that looks at high impact versus low efforts. And so they talked about specific techniques that focus on this as well that can really improve medical education. So what I found interesting was one of the things they talked about was bedside rounds. And I personally do not like bedside rounds and have a lot of opinions about it. But I thought what was interesting is they talked about this study where I think this was at Washington, they did bedside rounds and found that there was an increased improvement in patient satisfaction because the team was spending more time with the patients, and the patient actually had increased satisfaction with working with a medical student as well when they did bedside rounds. And that's usually where I always struggle with is how is the patient going to perceive us having a discussion with the medical student at bedside rounds? But the studies show that it actually does improve and has a good impact on it. A few other things that they talked about, which I thought was very interesting also, was about the practice of pimping and how apparently the reason why pimping has come into practice is because of a study that was done in 1908 on mice, where they showed that the mice being in stressful environment helped improve learning. So that's why we have brought pimping into medical practice. And so as you guys can see, how it relates to our current population of learners doesn't really relate to mice. So they've actually figured out that it does not help with learning in general. And so to take away the Socratic method of learning, taking it away from what do you know to more like how and why, and to keep it more open-ended. So I thought that was really interesting as well.
Well, I'm curious. Did they use pimping throughout the talk?
Like the term?
Yeah.
Yes.
Oh,
Because I'm pretty sure it's toxic quizzing
quizzing
now because, for the connotation of pimping in other circumstances.
And there was also a Things We Do for No Reason in the last year or so.
Yeah.
That was about the disutility, so to speak, of toxic quizzing. The first part that you were talking about, which was long rounds, basically. It's actually something I struggle with myself because when I trained med school residency, we saw every patient together every day, no matter how long it took. And I think there's a happy medium. I just haven't found it yet. Because I do think the fragmentation of rounds where there's 8 people seeing you at 8 different times also it's not a great feeling. So I do think there's a happy medium. And I'm always curious to see what the data to support or not to support are. And I'm sure our boss, Dr. Dan Hunt, is not a fan of the shorter rounds. He's really a big bedside teacher and residents learn a ton from him, but I'm a millennial, so I'm always going to err on the side of not.
Yeah, I mean, I can't sit still for too long, but I will say I've introduced bedside rounding into my practice and I've actually really enjoyed it. I think that it's brought both a lot more learning bedside. I also think it's provided opportunities for better patient care, at least from a communication standpoint, which I care a lot about. And so I think from that standpoint, it's been helpful for me. So I've enjoyed it. But I have gone through many iterations and I have asked every team that I have been on for feedback about it for months until I kind of have found more of my happy medium. And there are certain things that are non-negotiable and certain things that are negotiable with each team. And that part I make very clear, which is Dan Hunt advice. So
and just real quick, Moni, to kind of add on to what you were saying in terms of the length of rounding, they actually did a study where apparently 40% of the residency end up converting to bedside rounds. And apparently their rounds only increase from 95 minutes to 98 minutes. So interestingly, if you do it appropriately, correctly, then it doesn't add on to your time.
Good to know. Meredith, bring us home.
I went to very different sessions. So the first one I went to was decoding the microbial something.
Genome.
Genome, I think.
Genome.
Thanks. It was very interesting. It was given by a transplant infectious disease doc, but essentially what she did is we went through cases, and each case went through the different PCR like biofires you might have at your institution, which at our institution we actually don't have a lot. So it was a little bit more advanced in a way than what I was prepared for, but it went through it for, respiratory viral panels. If your facility has like the pneumonia one, that's separate from the viral one, for diarrhea, for meningitis, and for bacteremia. And she went through each of those and kind of went through the advantages and disadvantages of each of those tests. And sort of the take home that I took is that, I think I see biofire and I'm like, that's helpful. But actually there's ones that are, depending on the test, helpful at the beginning of the hospital stay because it's highly sensitive, highly specific, and it will help you like start narrowing antibiotics early. And then there are other ones that are actually just not sensitive and specific. And also the other thing that was a tidbit is that not all of them have the same sensitivity and specificity for each of the organisms on there, which then may create kind of this false positive, false negative situation when you get the results back. And so you kind of really still have to take in your clinical context and culture data to utilize some of that. But if you really understand what the tests are doing in each of those, which we can link to the show notes on the specific studies for all of those, then it could potentially be helpful. So I think that the way she was describing at her institution is it's actually paired directly with their antibiotic stewardship team. And so they will kind of help dictate when those tests are helpful and if and when you should order it, and then to thereby like help dictate your antibiotic ordering. So I thought that model was sort of like an interesting way to do it, especially if you're at an institution that really uses these. Then at the very end, she talked about there's specific ones that like, when you get the patient, you're like, surgery or someone had to go get a sample and they sent it for path, but they didn't send it for cultures. And now you're like, well, now we're stuck. What do we do? There's these newer tests that are like complete genome sequencing that like we may start seeing down the pipeline, essentially is what she was saying. However, for us, that pipeline may be longer, but more or less, there's also pitfalls to those. So it sounds like when you hear that it's like sequencing everything, it makes it seem like you could get data on anything, but it's actually DNA sequencing. So for example, it's going to not give you any information if your organism, for instance, is an RNA organism because it's only sequencing DNA. And so there's these other pitfalls to it. It's also not always covered by insurance. So if that's a barrier, and all these other things. So overall, I thought the talk was like pretty interesting, hit on some things that like definitely out of like our realm, or out of our realm because of like where we're practicing and we don't have all those tests, but we're starting to see more like we just got our own GI biofire. And so I thought it was like kind of helpful to frame like, hey, this is when this is going to be useful and this is when it's not going to be useful.
Yeah, I think I'm still in the phase of like not fully understanding what I get back in those tests. And so I have a very low threshold to call my neighborhood friendly ID doc. But I do think it's cool because that information comes about a lot quicker than the information that we're used to with cultures and stuff. So that part is helpful. But obviously context and sort of false negatives, all that stuff's really good, important to keep in mind.
Yeah. So sort of the take home that I think I took from it is in your patients that are potentially like, if you're immunocompromised, all of those things, you're probably still going to need help interpreting some of that data from your infectious disease colleagues. So just kind of keeping that in mind. And if it's a new test to your organization, then also reaching out to like your colleagues to kind of help you with that. And then the second session I went to, I'm just going to kind of plug because it was super interesting to me, but it's probably not as in line with like clinical pearls and medical education, but just inter-hospital transfers and best practices for that. If you are a hospital, I think they opened this session saying how if you have ever been on a receiving or sending end of a transfer, you feel the pain. And everyone was just like, ha ha ha, yes. It's just difficult and there's not really anywhere that has like best practices to it, but I thought they did a really great job at breaking up the talk and going through some of that. And I just think as hospitalists, as kind of here with SHM, those are the things that I think make hospital medicine different, and something that on any given day can be why you want to pull your hair out, and also be opportunities for how do we make the in-hospital experience for the patient better. And I think getting those wheels turning and things like that as hospitalists is really important. So it had a great turnout, and I'm like looking forward to see like what a lot of these other institutions are doing down the road, because I think it'll be hopefully better for patient care and kind of start setting up some models for what we should be doing in the hospital.
Yeah. It's the ultimate transition of care if you think about it, right? Because the stakes are still very high. I think when you discharge someone home, you're like, okay, well, they're better. They'll get home. It'll be fine. But when you transfer them to another hospital, like the stakes are still very high. And I think we can all agree, like communication and things is always the hardest part of those. Like, how do we hand it off? And like, in what form do we hand it off and all that stuff? So no, I think any talks about transitions of care of any kind are very important. So glad you were able to highlight it. But I think that kind of wraps up our first morning of sessions. We will be back at a later time, yet to be decided, about the rest of the conference, probably in some chunks. So there's no reason to stay tuned because you're just going to keep listening. Awesome. And we're back. We are still recapping SHM in beautiful San Diego. I had a glorious run this morning along the bay. And we're going to be recapping for this segment the first afternoon of the conference and then the second morning. So the caffeine is still sort of pumping through our veins. I think we can get through the session. So I'm going to start. So one of the things that's maybe not the most clinical, but certainly on top of mind, I think, for everybody is AI. And this talk was kind of, I think his goal, Dr. Z Chen, I think his goal was mainly to like get us thinking about, there's a lot of scary stuff out there, but wanted us to focus on a couple of things. The biggest point that he had to start was like, he actually had this like instrumental playing of My Heart Will Go On the piano. And he had actually played it himself. So he starts by talking about how, you know, he bought this $100 keyboard recently and it's a tool, and AI is a tool as well. And to not think of it as like this thing that's going to take everything over, but as something that still needs a skilled user to be able to operate properly. And so I think the most pertinent to hospitalists was kind of how it affects us on the day-to-day to do our job. And some of the things I think we're all familiar with are like kind of those prediction model type scores like sepsis. And then they had a couple interesting ones that he was using with their EMR at their institution. They had like risk of unplanned admission readmission scores to help prioritize patients for transitions of care clinic. And then some of the things they're kind of doing to come down the pike were, and we've heard of this too, like drafting responses to patient messages that you can kind of sign off on, summarizing the chart instead of just giving you the information. One that I think that we all would love is extract discrete data. So like the random test that you never know how to look up, it would be able to help with that. And then the last part he talked a little bit about was just collaborating in data science projects. And there's this guy by the name of Josh Starmer, and we'll put that in the show notes, that he recommends if you're interested in learning just like how these things work. There's way too much math for me, frankly, as someone who struggled mightily. So, but yeah, he said that they made it pretty easy. And if you're at all interested in it, great. And then the last point I'll say is he was like, remember, these are not sentient. It really just regurgitates information that is already out there. So really was trying to ease our anxieties a little bit and then highlight the positive it can do.
Yeah, that's going to be my only question. Did he say we were all losing our jobs soon?
No. And I think the conversation is more like making sure we educate people that is not going to happen. Like, because the layperson probably doesn't understand, you know, just how much the human brain does do in medicine. So all in all, you know, this was only one of the 4 talks they had at SHM this year about AI. And so it seemed, you know, I think it's top of mind. It was a packed house, and just want to throw a few little reassuring tidbits out there for everyone to remember.
I cannot segue out of AI into my topic, but I went to one yesterday on the care of the incarcerated patient for the hospitalist.
Actually, I think there is a segue there, which is there's lots of patient populations that require nuance, which AI definitely cannot provide.
Yeah. However, maybe there are other opportunities, because one of the things that they were really highlighting, and I think what I think is the worthwhile part from the talk, was one, each hospitalist has to be aware of what their own laws, rules, and regulations are in their own states, because it is not the same like across the nation. And in addition to that, every hospital has their own policies on how they prioritize the care of those patients. And so you really have to be up to date on that and know who your resources are in your hospital. And so talked a lot about, knowing where your risk management team is, knowing where your legal team is, and understanding a little bit of the financial aspects of that. But the two speakers were so passionate about the topic. And so it was really like an enjoyable experience because really talked a lot about like the mortality gap, really emphasized the low hanging fruit on, just don't get too bogged down into all of the legal parts. Certainly you may need to reach out to those resources, but your job is to care for the patients. And if that means having to maybe jump through the hoops and hurdles of figuring out how to legally get the shackles off the patient so that they're not developing pressure ulcers there or things like that, all of that is like invaluable to really providing optimal care for a population that is grossly like underserved probably, which I think a lot of trainees and providers care about. And so just kind of reframing a lot of that. And so I think they went into some specifics for their own experiences in Maryland, which I won't really go into because I don't think those are going to be applicable to everyone. But it just was a really great talk and just being mindful of like the resources you have in your hospital.
And I think it's important to have talks like that, kind of like the disabilities talk that we're talking about. You see, these are different patient populations. They should be treated with the nuance they deserve. So,
yeah, for sure.
Did you have anything to add? Okay. So, there was also, in addition to lots of AI talks, a lot of peri-op. And so I think Carol and I went to a couple separate sessions that were peri-op related. So I'll let you kind of start with the one that you went to.
Yeah, they covered a ton of high points, everything from endocarditis prophylaxis to post-op fever. But I think the biggest take home for me was how to manage patients with rheumatologic disease pre-op, especially the management of their DMARDs and their biologics. And they talked about how in 2022 and in 2023, each major sort of disease cohort, whether that was lupus or inflammatory arthropathies or IBD, each came out with separate guidelines on how to manage medications for each of those specific patient populations, which felt overwhelming until they shared a website at the end that was fantastic. And we can link in the show notes that you can just type in the medication and then the website will spit out on the other end based on their disease and disease severity, what to do with that. So I think that will really simplify how we kind of manage these patients moving forward. So that was really helpful. But what about you, Moni?
Yeah, I went to this. It was kind of fun because it was a debate setup. So there were two presenters and then they had to debate two sides of like to do or not to do kind of questions. And they made sure that they let us know that they may not believe in the things that they're saying. So that was entertaining. But the first case was about a patient developing brand new AFib on the morning of surgery. Like, do you call off the dogs? Do you anticoagulate them and then do the surgery? And it was an low-risk elective procedure. The first speaker was pro doing the surgery, like low-risk surgery. We don't want to irritate the patient. I was clearly in jest, but keeping in mind the reasons to always hold surgery, which this patient did not meet any of these specific conditions. They were unstable, volume overloaded, if they have valvular disease, AFib with RVR, or are they symptomatic? And then the case for anticoagulating and not doing the surgery is that there's a high peri-op mortality for patients with AFib, and really just kind of trying to sort through that. And then really importantly, that there's just not a lot of data on previously undiagnosed AFib. And so it's really hard to say. And to be honest with you, I can't imagine there's an anesthesiologist or a surgeon that's going to be like, sure, let's just do it, and appropriately. It seems like we don't have enough information to know what the right decision is. So I appreciated that. And then the second one was, should we be getting post-op troponins on vascular surgery patients? And the patient that they presented had a history of CAD with drug-eluting stents. That one I found to be interesting. One of the interesting take-homes is that three major cardiac societies, the American or AHA, the European Society, and the Canadian Society, all seem to agree that we should be checking them, actually, which was interesting because I hadn't really thought through that. And that being said, I think the point of both of these talks is that there's just so much nuance and all of that. And while there are guidelines, we probably don't have enough data for any of these decisions, to be honest.
Did they say why you checked that?
They had this whole section on like an elevated troponin without, like they call it the MINS. And they, said that there was an increased potential risk of mortality, but then the other speaker pointed out that it was all-cause mortality and not just cardiac event. While those societies all seem to agree on something, it did seem like there was enough information out there to where you could probably make the case for the opposite. But it was really interesting, and I was just entertained. I mean, it was just fun to see people egging each other on, and they had all these studies and stuff that I hadn't really seen before. So we'll have a few of those in the show notes. So yeah, some good peri-op content there. And obviously the studies will be in our show notes. Carolyn, I think you went to something about almost an update on one of our old episodes.
It sure was, Moni. It was an update to episode 358, which we had covered previously for onc-emergencies. But one topic we hadn't quite dived into as deeply was neutropenic fever, which I know at our CASHLAC get our fair share of. And they went into a couple of salient points. The first one, I think, was a clinical decision score for who can be managed outpatient versus inpatient, which I hadn't quite thought about. It was a score called the MASCC score, and it kind of incorporates their functional status as a patient, as well as if they can get back to the hospital in a timely manner if they decompensate. So that, I think, gives some insight to our ED colleagues who are trying to decide which of these patients to admit. And they did add in some expert opinion that any patients that are actively on chemo, they do recommend get admitted to the hospital regardless of this risk score. So that was point one. And then point two, they reiterated, when we need our GPC coverage in limited patients, if they have pneumonia or indwelling line or a pneumonia or a skin and soft tissue infection. But they asked the age-old question of, your neutropenic fever workup returns negative. How long do you keep on the broad-spectrum antibiotics? And kind of like you were referencing earlier, Moni, there's some discrepancies between the big societies on what to do. IDSA and NCCN favor keeping them on until their ANC comes up over 500. But the European Society cites a really cool study called the How Long study that was done in Spain. I know.
Good name.
And it's not even cardiology, right?
Yeah.
So How Long, and they looked at some high-risk patients who had neutropenic fever, then they had negative blood cultures and then hadn't fevered for 72 hours. And whether, even though, their ANC was still low, they could stop antibiotics safely, and they did find no worse outcome. So we'll link that study as well. But that's what the European Society cites as maybe we can de-escalate at 72 hours of being afebrile. So I thought that was an interesting pearl as well. Yeah, other than that, we really have covered a lot of those topics in our earlier episode 358. So check that out if you haven't yet.
Cool. And I think Matt and Paul did neutropenic fever on its own. I just don't have the exact
288.
Sweet.
And it was a live episode.
Yeah. Cool. So I guess it sort of segues into one that I went to today. The whole lecture was on essentially the pros and cons of like IV antibiotics versus oral antibiotics. I think a lot of hospitalists are seen over like the last year or two a lot more studies coming out about kind of like how you can use oral antibiotics, that they're just as good as IV. And so what are kind of like the reasons that we've been doing IV for so long and all of that. And he talked about it in kind of 3 common infections: endocarditis, osteomyelitis, and bacteremia. And so broke it down into those 3 segments. And really for all 3, largely like oral antibiotics are just as good as IV. And the reason we've been doing like IV for so long is really based on a lot of like history going back to when like antibiotics were a brand new invention. And so there actually just wasn't good data, and the data was comparing it to like kind of just not doing anything, not really comparing it to IV versus orals. Like it just makes sense. Like IV should seem like it would work better, but like trust the studies, and like the background to that may not be the most reliable source. But the other thing that he brought up also at the end that I thought was really helpful is like framing when a patient may benefit from IV therapy. So you can't just say like, oh, well, I have this data that orals are just as good for this infection. Like, does the patient have some sort of reason they're not absorbing antibiotic through a PO route, and so therefore I do need like an IV therapy? Or is there like another reason from like a social standpoint that IV therapy maybe in a rehab or nursing home may be like a more effective route for the patient rather than trying them on oral therapies? So you still have to take all of that into account, which I think that's like the classic nuance of being a hospitalist, is you always have to like think about like dispo planning and transitions of care and all of that. So I thought that was like really helpful that he kind of like framed that up at the end, that there may still be benefits to doing IV. But in general, like from the hospitalist perspective, the other thing that I thought was really interesting is like how much it decreased length of stay by using oral antibiotics, and then the costs by association of that. So I thought all of that was like super interesting to like think about. And sort of my take home point from it was like, we should be confident in using oral antibiotics if the patient is a good candidate for it. The other one that he said that was just like a fun kind of like tidbit is, and I'll cite it in the show notes too, but they did like a study comparing like, like if we're going to do orals, like, do you even need your infectious disease consultant anymore? And so they
Bold.
I know.
Oh,
And so,
shots fired.
but the study actually found they essentially like compared like 30-day mortality in endocarditis and broke it down like into improved mortality if you got echo, ID consult, and plus appropriate therapy. And so obviously if you got all three of those things, you had like a pretty good like 30-day mortality. But then they broke it down into the individual things. So if they only got the echo, if they only got like appropriate therapy, or if they only got the infectious disease consult. And if they only got the infectious disease consult, their mortality was significantly better still than just like getting appropriate therapy. So it's not just like the antibiotic choice. There is something that our infectious disease colleagues are doing that are still like helpful for that. So just still highlighting like, just because you're switching to oral, I feel like I do this all the time. I'm like, I'll consult ID and be like, I feel like I can do oral, but am I picking the right antibiotic? And that's sort of what they're hypothesizing at the end, is that ID is still helping with like targeted therapy faster, sooner, maybe also helping with that for the patients.
I always make this joke, and this feels like it's proof of that, which is whenever I call ID, it's like I'm actually calling a real doctor consult. Just the amount of attention to detail that they have, I just like have so much admiration and respect for, because I certainly need their help a lot. And it's funny that you say that, a lot of this is just dictated by history, the way we use IV antibiotics, because our meningitis episode, I remember the guest that we had, Dr. Payal Patel, telling me, meningitis guidelines haven't been updated since 2009. We just really haven't tried to look into if we need to be changing stuff, right? And I think that for a lot of ID stuff, because, the stakes are pretty high in a lot of these infections. So I'm glad that there's a movement, however, to being more mindful of the resources that we have.
Yeah, agreed.
All right. We will be back with another chunk here in a little bit about the updates, the big articles of the last year. We are at the end of the second day of SHM in San Diego, which has been a whirlwind so far, and we still have a half day left, but we're super pumped about it. And to celebrate that excitement, we're actually going to talk a little bit about what we learned this afternoon, and we're going to start with kind of the premier session every year, which is the updates. They pick articles from the past year that are practice changing, and we picked a few that seemed like really, really pertinent to our practice and really practice changing. So, Caroline, I think you got to do one with a clever name, Cape Cod.
I did. It looked at whether or not we should use steroids in pneumonia, which has been, as we know, visited time and time again. But this did have some interesting and I think some practice changing points in it. They looked at patients who had severe community acquired pneumonia, or CAP, and that included patients who were intubated. And at our Cashlack, we don't practice in an open ICU, but there's also patients on the floor that would qualify for this, which I found interesting. Patients who are on advanced oxygen delivery devices, including a non-rebreather or high flow, if their P to F was less than 300. So we could be encountering these people on the floor. But it looked at whether or not they had, differences in intubation rates, changes in pressors or mortality, if they got the sort of standard stress dose steroids of 200 of IV hydrocort per day. And they did find that these patients had lower intubation rates if they weren't already intubated, lower incidence of needing to start pressors, and lower mortality with a number needed to treat of 18 compared to a placebo. And the sort of feared side effects of steroids weren't seen. So they didn't have more GI bleeds and they didn't have more hospital-acquired infections. They needed more insulin, but I think that's minor in the scheme of having an actual mortality benefit. Some of the caveats, though, that I found interesting were that the median time to start steroids was 15 hours after they got into the ICU. So I don't know if this is going to be as practice changing on the floor, comparing to kind of like our sepsis bundles that we initiate within a couple of hours of identifying this, but still something to keep in mind if you are managing patients as they transition into the ICU. But I think that's another data point in our saga of steroids and pneumonia.
Yeah, cool. I'm going to recap a little bit about the Prevent Clot trial. So that was looking at the ever lasting battle between aspirin and enoxaparin for post-op BT prophylaxis. So there really wasn't a difference in all-cause mortality or bleeding risk, but interestingly, there were higher rates of DVT in the patients that got aspirin. And then the thing to keep in mind, though, about this study, that it was predominantly young patients. It was like traumatic fractures. They're predominantly male and predominantly healthy. So can we extract this to a larger hospital medicine population? Probably not. But if you do have that specific patient, something to think about. And I think we were talking about this before we went on, which is the surgeons are probably pretty happy, right? Like they're not getting some of those things that they're worried about. But as hospitalists, we're the ones probably discharging a lot of these patients and sending them home on anticoagulation for this DVT, or they come in with a new DVT after their surgery, like that sort of stuff. I'm not sure we're too excited about, but yeah.
Yeah, we say the elephant in the room.
What's that?
You're prescribing this medicine, arguably, to prevent clot after their surgery.
Mm-hmm.
So if one has a higher rate of clot after the surgery, it doesn't feel efficacious.
I mean, the woman has a good point.
But that's just me.
I mean, you're just stating the facts. Just stating the facts. Meredith, we're going to talk a little bit about AFOTs.
Yeah.
Best name of the afternoon.
I don't know. I mean, you have AF, which I guess has just been overused at this point. So kudos to them for coming up with something different. Although I don't know that it's a word.
It is not.
Yeah, but here we are. Yeah, so in updates, they talked a little bit about the AFOT study, which interestingly had actually come up in another session I had gone to earlier today as well. So I'm going to kind of mix and match a little bit of the facts from it. But AFOTS was looking at, transient AFib and kind of what happens when someone comes in for whatever reason, infection or whatnot. They end up having AFib briefly in the hospital, a lot of times spontaneously convert. And then what do you do about the anticoagulation afterwards? And so the AFOT study specifically looked at those patients and their 12-month follow-up. And about 1/3 of the patients who had that transient AFib experience in the hospital ended up with AFib over that 12-month period. And so a lot of those then, got recommended for like anticoagulation. And so the question is, kind of in that transient phase, like what do you do with anticoagulation? And interestingly, in the other talk that I had gone to earlier in the day talking about this, AHA had put out a scientific statement in the last year kind of addressing this, that in the same vein, a 5-year recurrence rate of the AFib is anywhere between 42 and 68% in patients. And so given that risk of recurrence, it makes sense to consider anticoagulation, especially if their CHA2 VASC is high, in line to like prevent their stroke risk. So I think kind of combining both studies and the AHA statement, I often am like, that just happened in the hospital. I'm going to ignore that and assume that it's in the setting of all these other things. But it does seem like maybe there is more value in the anticoagulation piece at that time and ensuring that they have adequate like cardiology follow-up if they're going to need any additional therapies in the future for their potential now paroxysmal AFib that you're predicting.
Yeah. I think that was the paper where they said like at least 1/3 of people have a recurrence.
Mm-hmm.
Yeah. So it's crazy. But not too surprising, I guess. I mean,
no. And I think the other thing that they said is the patients who end up with this tend to have a higher percentage of them have left atrial enlargement. So it kind of makes sense from an anatomical like perspective that these are going to be patients who are at risk for this occurring. So at least like from a just logical standpoint, like I could follow how we like got there in all the studies versus like I think sometimes in some of these studies it feels like we're making some assumptions. It definitely made sense both from an anatomic and physiologic standpoint.
Cool. To kind of wrap up the updates part, we're not going to go into the full details because I think we've covered it ad nauseum in the past, but the management of inpatient hypertension and non-cardiac patients, take home point, just leave it alone, guys. The outcomes aren't good. Our episode 310, which was our first ever episode with Curb, we went through a lot of the same kind of information. This study in particular definitely wanted to highlight the fact that don't do it, period. But if you must, again, definitely don't use IV. Because the outcomes were even worse with IV. So, but those were the key points from the update session this afternoon.
Yeah, and the other thing I'll just add from the updates, there are a few other studies that got mentioned, but I think they've been highlighted in other modalities throughout the year, specifically on like different hotcakes episodes. So if you guys, make sure you're listening to hotcakes to kind of keep up with the latest practice changing knowledge.
Word. So I know we just finished some updates, but there's more. There were 2 really great sessions before the big update session earlier in the day where they talked about critical care updates and some guideline updates. And Meredith hit some of the high points that kind of overlap the 2 sessions. But Meredith and Caroline are going to talk a little bit about some of the stuff that was a little different and maybe additive.
I can start. They covered a couple of different disease states in the critical care updates. They started out with ARDS. There's a new definition on the block since the Berlin definition in 2012. A lot of it's the same. Came out in May 2023, but they made it a little bit more inclusive of different practice environments. So, for example, patients who are on the floor and not intubated. So if they have high flow or if they're on non-invasive positive pressure and they still have those characteristic bilateral infiltrates that are non-cardiogenic, they're saying that we can now call those patients ARDS. And they also opened it up to say that you can diagnose those pulmonary infiltrates with POCUS if you're a trained POCUS provider. Again, I think just opening up in your acute hypoxemic respiratory patients, if you're in a rapid, you don't have to wait for a chest x-ray or cross-sectional imaging to really confirm that this patient has, evolving ARDS. So I think that's helpful for our sort of step down peri-ICU patients to have that more liberal definition of ARDS. And they also talked about, on the note of steroids in the lungs, ATS came out with some new recommendations on ARDS management. And now they are kind of in the middle, like conditionally, this might be a good idea to use steroids in ARDS across all P to F ratios. So just another data point, again, in the steroids and lungs conversation, but that's discrepant from the European guidelines, who made absolutely no mention of steroids in their most recent ARDS guidelines. So up for debate still.
Love that.
I'm just impressed with how many times you've casually mentioned the P to F ratio, and I'm having a hard time digging through my basic science knowledge to know what that is, but I'm going to look it up after we're done.
Link it in the show notes.
I guess because we're talking about ARDS, I'll talk first just a little bit about GOLD guideline. This is something that as a statement I knew, but until someone said this to just like really bring it home to me, it hadn't connected exactly. So for the GOLD guidelines, if you are a hospitalist, the group E patients include anyone who's had greater or equal to 2 moderate exacerbations or greater than or equal to 1 exacerbation leading to hospitalization. Essentially, that means this is the part that had never connected. If you are seeing them in the hospital, they are in that group. And it can be on the first time. It doesn't matter if it's more than that. They're already going to have qualified for that. And so therefore, that's their LABA/LAMA. And then the only other thing you really have to check for like making other decisions for their medication is if you're seeing greater than the 300 EOs to add the ICS to their inhaler. For whatever reason, I think I was thinking about like moderate exacerbations more and like is that what's counting in the hospital? So just someone like laying it out and me seeing it on the slide, that was the first time that connected. And I will be the vulnerable person on here to say, I didn't know that until today.
You just blew my mind. So
it's definitely practice changing. I think it helps us as hospitalists escalate care the same way that we escalate GDMT for heart failure. It's so much more simple, so much easier to follow, and will improve, like you said, these discharge patients as we hand them off to PULM in the outpatient setting. So yeah, I think it's huge.
Yeah, I agree.
I've got a couple other points from critical care. A couple points on sepsis. In JAMA in 2023, we were looking at patients who have septic shock and on our pressors and comparing the sort of standard stress dose steroids of hydrocort alone, the equivalent of 200 a day, to whether we also need to add fludrocortisone on top of that. And there is a benefit to having that combination therapy, which was definitely practice changing for me to hear about. I think we'll see how that plays out with outcomes, since this was the first time we've, I think, seen that in a randomized control trial, but that was huge for me. I've got 2 kind of happy points in the critical care world to end on.
Great.
One was on mortality and sepsis. It was called the EXIT SEP trial, 2023 JAMA. And it was conducted in China, and it was looking at the effect of an herbal-based injection, and forgive me if I don't pronounce this right, but Zubishing It's abbreviated XBJ, on the 28-day mortality in patients with sepsis, and a pretty astounding mortality decrease with this therapy from 26% to 18%. I mean, like numbers we don't normally see. So I thought that was exciting. They brought up how that would be a little bit challenging to work through the FDA process since it is a true like herbal medicine. But I thought that was an exciting point on the horizon for sepsis. And then a sort of also happy point in the AI realm, since we talked about that a little bit in our earlier session, that they looked at in JAMA in earlier, I guess this year, it was about a month ago now, individualized treatment plans for patients who are intubated, kind of trying to pick whether they were going to benefit from a low or a high SpO2 target. And they used machine learning to try and make these, look at all their characteristics and see who would benefit from different parameters. And they were able to show some benefits there. And I think it will help us phenotype our ARDS patients and really demystify why some of these patients act so differently on the vent. So yeah, some promise with AI there. They won't get us yet. Not today.
Or will they?
Maybe tomorrow, but not today.
I'm just going to maybe round it out with a couple of things that are all kind of intertwined.
Great.
Cool. I think we have talked about these on previous episodes a little bit, but just wanted to maybe define a couple of things for everyone. So acute left-sided colonic diverticulitis has been kind of like a popular topic recently, and that can treat outpatient without antibiotics if it is an uncomplicated case. But I think that one of the things that is tricky is like what really defines the complicated versus uncomplicated. So spelled that out, complications would be abscess, phlegmon, fistula, obstruction, bleeding, or perf. And one may argue that like if they are coming into the hospital, they potentially have that complication, like have some sort of complication or question of complication. So you're most likely not managing that as like the outpatient without antibiotics, but certainly comes up for like our colleagues in the primary care world. And then the other thing is like those studies excluded like SIRSy looking things and immunosuppression. So those are often the ones that get omitted. And then on the same token, like kind of moving down like those same guidelines or similar guidelines, I should say, remembering that if someone is having recurrent diverticulitis, to, get our general surgery colleagues involved to consider colorectal surgery for like ultimate management of the diverticulitis, which I think, I don't know, maybe I just haven't seen a lot of diverticulitis recently, so whatever, but I just haven't been thinking about that as much. So just shouting that out. And then lastly, kind of also still in the gut, management of patients with acute lower GI bleeds, just some updated ACG guidelines. So this was interesting to me. So patients on DOACs, they're recommending reversal of the DOAC if you're experiencing like a life-threatening bleed, which makes sense. But the other thing is they actually recommend pretty quick resumption of the anticoagulation after cessation of the bleed, as it reduces risk of the VTE risk and mortality. And so trying to resume that within 7 days of you having to stop it on the inpatient side. So I thought that was kind of helpful to just have as like a marker, because I think that like often we stop it and you're like, hey, am I going to cause them to rebleed? But actually the ACG guidelines want you to start it once the bleeding has.
Even without definitive treatment?
No.
You got to fix it.
Yeah.
And then you got to start it.
So yeah, like you have to have the scope, make sure that like if anything can be fixed, has been fixed. But my understanding at least, and this I guess could be wrong, but at least what I took away was like, if you've been scoped, can't find a cause, still can put them back on their anticoagulation and see.
That's spooky.
Yeah, spooky, but definitely an update from our GI bleed episode about a year and a half, 2 years ago. Those guidelines, I think Dr. Dira had actually told us that those are being written as we were recording, essentially. So they're finally here. So dive in. We'll link them in the show notes.
Yep.
Great. So I'm going to round it out with something that's maybe not the most directly clinical, but certainly something as hospitalists top of mind all the time. I went to this talk about post-acute care. I think I went in thinking this was going to be about like transitions of care clinic type stuff, but that's just because I probably can't read the description of the talk. And it was actually really interesting. So it talked about where patients are dispo, right? Like that's what we all think about constantly. And I got to say, some of the statistics were pretty grim. So we all struggle with knowing like what's the right amount of post-acute care? Why does it even matter? So they did this study where they asked like hospitalists from 15 institutions on a given day, how many of your patients are just literally just waiting for placement? And the answer to was roughly 10%. No medical issues or just waiting for placement. Of those patients, greater than 50% had been waiting for over a month, and 15% of all those patients of the list had been waiting for over a year. And so I think everyone that works at a hospital thinks it's only to their institution, but clearly it's not. Was that uplifting? No, it was not. It was really disheartening, actually. So that's how many people are waiting for beds. And they actually talked about how something similar happened in Japan, where it just got these stays just got longer and longer because there's really no other place for patients to go necessarily. So that's just waiting for beds. When they actually get a bed, less than half of them will actually make it home, 45%. So when you talk to a patient about you just need to get a little stronger, we're going to send you there, the realistic conversation is it's actually more likely than not that when we send you here that you will end up staying there in some capacity or be readmitted. So that's the twofold. It's you'll either go home straight away, less than 50%, about 45%, or the other two outcomes were readmission versus just staying there past 100 days. And then some more enlightening stuff that we just don't think about. So they asked the whole room to answer what do you think the nursing ratio is? And there's a bunch. It's 18-1, which is, we all know, not great. And then, his best advice in general, though, was just, he was like, I know every hospital administrator is going to yell at me for saying this, but hold the patient a day to try to sort out how to make home work for the patient, because it's studies they've done that compare home health versus SNF SAR type things for some of these patients. The outcomes have actually been the same, especially in patients with dementia. And one of the things that his system was doing that I found to be interesting, one of the offshoot sites of his institution had this partnership with a SNF where they sent the doctors to the SNF to see if they could work on readmission type things. Because those are the things hospitals care about, right? It's how do we decrease readmissions? Well, partnering with these SNFs in your community and trying to figure out ways to train up the staff and give them sim teaching and stuff. And so, I don't know, there was a lot in there. It's going to make me think a little harder about some of these decisions. Of course, a lot of times it's, families unable to or whatever. But I think we can all think of examples where a patient waited for a bed for a very long time, and then we called the family one last time, and the family's like, okay. So I really did like that. Just give it a day, give it one more day than you're used to, or just sort through it a couple more days than you might want to, and you might actually get it something that's better for the patient.
I think it validates patients' fears that they're not going to go home to. I'll admit that I've definitely dismissed that. Didn't know that it was over half would never really get to go home again. So that'll definitely inform my conversations with patients around placement in general.
Anything to add, Dr. Trubit?
I think that one of the things that I take away from this, and this I noticed too when I have learners, is I think that there's a disconnect between what we all understand
and what actually happens, which is kind of the point of the talk, I think.
Yeah. So I think that it's 1 to 18. So which is standard, but they're also not, that nursing staff is not expected to be
the kind of nursing that we have in that.
Right. Which is also why those patients come back to you and you're sometimes why did they come back? Well, it's a different care situation. And this is sort of what we were talking about actually with our psych episode that you guys will get to hear in a couple months. That we recorded here is, being really mindful of what the different care environments look like, what can be provided and who might be best suited to care for that patient. And I just realized I don't think we went to any of the hospital, or I don't know, did they have any hospital at home sessions this year?
Not this year.
Yeah. So, but that's definitely, I think, something that's down the pipe and potentially we'll see more of in the coming years.
Yeah, there was one more thing I realized that I wanted to touch on, which is, and I'm not sure where we work will be as relevant, but for other people, they did studies about, the quality of the places that you're sending the patients to as well. And there's actually tools to help people pick, and you can look it up yourself. One's called Medicare Compare and one's called Nursing Home Compare. And the study showed that 85% of Medicare beneficiaries could have been placed at a facility within 15 miles of the one they went to that was better. So just kind of being mindful and trying to work through some of that with the patients, I think would be good to think about.
Yeah. And I think that goes back to, I think what your speaker was saying is that though may mean that you're keeping them an extra day to find the right place. Yeah. And I think that's sometimes not the answer that administration wants.
Correct.
Yes.
So we're always struggling to try to balance all of that to do what we think is best for the patient. So awesome.
All right, that's it for day 2. We will be back tomorrow for our last half day of SHM.
And we are back. And if they did their editing job, no one will know why this is hilarious, but it really is the last day. Due to time constraints and time changes, not the very last session, but very close to it for SHM in San Diego this year. Really great morning to kind of round out the conference. And what is a hospital medicine conference without a little things we do for no reason with Tony Brew and Lenny Feldman, both friends of the pod. Caroline, can you start with the first one of the things they covered?
Yeah, we went over 2 articles. The first was what to do when you see incidental coronary artery calcium on your friendly CT scan, whether that's with or without contrast. And indeed, we cannot just ignore it, even though that might be tempting. And there are ways that our radiology colleagues can score that coronary artery calcium, despite it not being a formal coronary CTA scan. They can do it both with numbers and do integrals and create a score, some of those familiar ranges that we've seen, like the 0 to 100, 100 to 300. But they can also just sort of subjectively say whether there's no coronary artery calcium, mild, medium, or severe. And then based on that, there is some data to show whether we should be putting people on statins, or even with these really high coronary artery calcium scores, whether we should actually be putting them on an aspirin and a statin. There's some data that shows that their MACE and mortality mirrors people that have known CAD. So something to keep in mind, and something to, I think, discuss with our radiology colleagues if we're not seeing them comment on the coronary artery calcium on every CT chest that gets done. So definitely something that will change my practice when we go home. But what is the other article they talked about, Moni?
A little bit of anemia. Again, what's a conference without transfusion stuff. So Tony Brew talked a little bit about, this seemingly arbitrary cutoff of 7 for when we transfuse asymptomatic patients. And, the a few tips, because I don't think they have a great other answer from below 7 at this point, but a few things before you start transfusing people to think about. First of all, and we all know this, stop drawing blood every day if you don't actually need it, because that is iatrogenic. We're just decreasing people's hemoglobin simply by taking it every day. The other thing, you should probably investigate why the patient is anemic to begin with. And one of the things he said that he was trying to implement in his practice was to do more EPO for patients that might benefit from it. And specifically, which patients, don't know if he went into the details of that, but that was one of his other tips. And then the last was, I think this is something I'm guilty of, which is I see a patient's hemoglobin drop to 6.9, and I don't go into the room talking to the patient about it. I don't ask them like, oh, are you more short of breath today? Are you more dyspneic? And all that stuff. So talk to them, evaluate them, see if they really would benefit from it. And this, again, with this cutoff of 7 for hemoglobin this excludes cardiac patients and patients with an active GI bleed. So please also still be doing those practices that you do for transfusion for them. But this is those patients where they've been there forever, you're checking daily labs, and they get below 7, and just be really mindful of that. And he did go through some of the physiology, a lot of equations that I don't recall from med school about how you're going to have to help me out here, Caroline.
What we actually care about, like the tissue perfusion.
The tissue, yes.
We go from cardiac output and hemoglobin down to what the tissues actually extract. It was nerdy and awesome.
It was nerdy and awesome. And there was a study from the 50s, I believe, that they had patients with an average hemoglobin of 3.7.
One guy with a 1.8.
And didn't really have a change in tissue perfusion.
Yeah, it was wild.
And that's in his slide, so hopefully we can drop that in the show notes. But those are the 2 things we do for no reason. But I think this little blood action kind of dovetails nicely into what you went to this morning.
Yeah, so I went on to the talk on iron deficiency anemia. The 2 speakers had recently actually kind of published a review article on iron deficiency anemia and JHM. So we'll link that in the show notes, because that's kind of was the model for their talk. But I thought kind of a couple of highlights to dovetail what you guys were saying was be relatively aggressive about checking for, your iron studies in patients that you see who have anemia, and then advocating for, considering IV repletion, especially if they're hospitalized. And some reasons to kind of consider IV over oral included, if your patients are constipated, IV may be a better option. Poor GI, like malabsorption issues, as well as severe anemia, that they're going to benefit with IV transfusion or IV iron infusions faster. And there's sort of 3 conditions that patients may have that they're also going to just benefit from IV iron. HFrEF is the first one, which I think has been like the hot topic recently. End-stage renal on dialysis, they should also be considered for IV iron, and they have like kind of different thresholds you should think about for their ferritins and everything. As well as the new one to me was malignancy. So patients with malignancy who have chemo-induced anemia can benefit from IV iron because it just corrects their anemias faster. It improves their fatigue and quality of life. And from that perspective, that's kind of what drives that recommendation. And then the other part that I really like that they went into is kind of like debunking, I think, some of the myths about IV iron. So just kind of thinking about like, are you worried about infection? What's kind of really the risk of like co-infection? So unless you really have like active bloodstream infection that's not controlled, you're probably okay still doing IV iron. And then the other thing they talked about was IV iron induced reactions. I actually did not realize this, but it is a different mediated reaction. So it's complement mediated instead of IgE mediated, which was just relevant because you're actually supposed to give hydrocortisone for that, not diphenhydramine or like other things. And in the studies they actually have done looking at that, most of them don't need epinephrine, which makes sense because you're not having like an IgE mediated like anaphylaxis. And so actually the European guidelines don't even recommend that you have to do like the test doses or anything. So some hospitals have moved away from requiring the test doses specifically for dextran for that reason. So I thought that was interesting. And those were kind of the highlights from it. They also went into some equations that I was like talking about their iron deficit. I'd never do this. I don't know if either of you.
Guilty.
Yeah. But kind of what they were, I think, really highlighting from that is that we are probably very much under treating their iron deficits. And so be aggressive with it. And you can kind of calculate that out to know. And then to make sure that they have adequate follow-up to like recheck those stores and see if they're going to need more in the future.
Okay, that's good to keep in mind, I think, about the iron stuff. No segue, really. Community-acquired pneumonia. Joanna Bonsall out at Emory gives this talk every year and always manages to find some update, which I think is really impressive because we all treat community-acquired pneumonia probably once every time we're on service. I think, last year we covered a little bit about Procal and stuff, which maybe wasn't the newest, but we've covered the new steroids recommendations ad nauseum earlier in the episode, so just kind of flip back to that. But the one part I wanted to highlight, and I'm not sure if you mentioned it with the molecular assays part earlier in the episode, but she did talk a little bit about molecular assays related to respiratory infections. So the study, a couple things to keep in mind. The negative predictive value was actually quite good. So if it's negative, really feel good about things. And the thing about the study she didn't really like was obviously quality of sample is always the issue with testing with the sputum. And she said, because a lot of us don't even have it, and then like sample quality is always hard to find, probably not the most practical test to be doing. So we all know there's biofires for everything these days, but the quality of the study or the quality of the testing is so user dependent, patient dependent, that probably not something you should like be relying on all the time. So
they did mention it in the talk. I don't think I actually specifically said that at the beginning of the episode.
Cool. But yeah, that's kind of what I gleaned from that part, that talk. And I think you're going to bring us home with the real uplifting stuff.
So palliative care this morning, they talked about a lot. I don't even think we could recap all of it, but I'll just kind of highlight, I think, what the take-home points were. So there's actually been a lot of studies that have come out in the last year and a half on palliative care. Obviously, because it's palliative care, it's a little bit more based on like, observational studies, less kind of like really strong randomized control trials. So some of that means like some of this information you're taking with a grain of salt and really having to still like extrapolate that to the person you're seeing in front of you on a day-to-day. But I think that 2 things that like struck me, one, make sure we're considering like methylphenidates for our apathetic patients based on the ADMET-2 trial. So if you're talking about kind of end-of-life care, I actually saw improvements in scoring at 2 months and sustained it at 6 months. So it does help in the outpatient setting, even though you may not see the initial benefit on the inpatient side. So kind of working with either your palliative care colleagues or their primary care doctors to see how they would feel about doing that. The other one that I found was kind of together and interesting is it's important to be priming our patients on goals of care. So the way they described that was in the same way when you have learners on your team and you are like, this is feedback, and you wave them in that this is feedback. We should actually probably be doing that with goals of care as well. There was a study that was done essentially that providers were documenting goals of care conversations that they felt were really clear. And then afterwards, the families were getting surveyed and they were like, I've never been asked about goals of care. So just like going in and saying, I am doing, advanced care planning. This means we are talking about end of life, goals of care, what you would want in these circumstances, and really waving them in so that they know that. And I thought that was interesting. And that also just kind of helps in the future too, like on future hospitalizations and like, so everyone's on the same page and you're not starting from, ground zero with each subsequent hospitalization. And then the other thing is that I'm just going to I plug this for my learners, but ePrognosis is like a website where you can get like the different scoring systems for, based on where the patients are, kind of what maybe mortality is. And they've actually just recently added some prognostication tools for patients that get admitted with dementia. And so I think that's usually like a helpful category that we should be looking into. So just wanted to plug that as well. So I think I'll stop there unless anyone has any other comments.
No, waving them in. This is feedback. I am doing teaching now.
Yes.
Very fitting.
We can wave this in and say this is the end of SHM.
Oh, wow. What a segue there, Dr. Trubitt.
Took all conference, but we got there with the segue.
We did get there. So with that, I've been Dr. Moni Mean from SHM in San Diego.
I've been Dr. Meredith Trubitt.
And I'm Dr. Carolyn Coleman.
Thanks, and see you next year in Vegas.